Good afternoon, everyone. I am Melissa Bustamante from the Illinois chapter, American Academy of Pediatrics, and I thank you for joining us for today's webinar for Measles, Old Disease, New Resurgence. Today, we are joined by Dr. Jennifer E. Layden, Chief Medical Officer and State Epidemiologist from Illinois Department of Public Health. Before we begin, I would like to go over a few housekeeping. Participant phone lines are muted. This webinar is being recorded. Everyone will receive a copy of the PowerPoint slides, a link to complete the evaluation, and a link to the recording of the webinar by the end of business day. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar located on the right-hand side of your screen. The question will be answered at the end of the presentation. And to introduce our speaker today, Dr. Jennifer Layden is the Chief Medical Officer and State Epidemiologist for the Illinois Department of Public Health. She is clinically trained and board certified in internal medicine and infectious diseases and holds a PhD in epidemiology and public health. Dr. Layden completed her medical and public health training at the University of Illinois at Chicago. Prior to joining IDPH in 2016, she was on the faculty of Illinois University of Chicago in the Departments of Public Health and Medicine. So without further ado, we will welcome Dr. Layden.
Hi, thanks everyone, and thanks for the opportunity to talk to at this time. My name is Jen Layden. I'm with the Illinois Department of Public Health and serve as the Chief Medical Officer and State Epidemiologist. I think it's really important and timely that we are addressing the issue of measles, given what's occurring nationwide, and we're really, which we're paying careful attention to, so that in the event that we get additional cases here in Illinois, we are ready to respond. I don't have any disclosures, and I do not intend to discuss any unapproved or investigational products or devices. So in this webinar, my plan is to review the recent epidemiology of measles, both in the US and here in Illinois, addressing the questions of where, who, how, review clinical presentations. That's an old disease that many of us have not clinically seen, so it's important to review the clinical presentation, as well as the diagnostic approaches that can be used to confirm the clinical suspicion. And then I'll review and highlight the role of public health and how that intersects with clinical medicine in our efforts to control and prevent measles outbreaks. So in 2000, measles was actually declared eliminated in the US. And what they meant by that was that there was no evidence at that time of ongoing sustained transmission that was endemic to our country. Certainly we would see periodic cases, but those cases were cases that would come in from someone who had international travel and had been exposed elsewhere. Unfortunately, since 2000, we have seen a rise in cases. And most recently, we've seen a spike in this past year. In 2019, and this is as of April 11th, 2019, and is based on CDC data. Measles is a reportable disease, and so all cases get reported to the CDC. And for 2019, you can see that we are already well above the number of cases we had in 2018, and we are only in the first few months of this year. This number gets updated every week by the CDC, and we are already in the high 600s as of today, unfortunately. So where are we seeing cases of measles in the United States? Currently, there are many states that have had cases, either isolated cases or outbreak. Here in this map, the blue states are the states that have had identified cases, in 2018. And during this year, and really during the end of 2018, we've seen a lot of outbreaks. And this is not a comprehensive list of the outbreaks that have occurred, but a sampling of some of the most significant ones, and from ones that we can learn certain lessons. The New York State, part of New York City, and some of the surrounding counties of New York City, and other parts of New York have seen significant number of cases. And you can see the date that this was last updated. Those cases continue to rise. They're not seeing at this point a decline in the number of cases. Michigan most recently saw a jump in cases, and we'll go through the details of how they got to 42 cases in a matter of really about a month's time. When we see cases like this, it begs the question of where and how we're having cases appear in the United States when, one, we had declared it eliminated in 2000, and then two, overall, if you look at our vaccine rates, they're relatively high. And there's several factors that are contributing to that. One we know is that in many countries, developing and developed countries, there's a high rate of measles and high incident of measles. And in many of these countries, there have been actually significant outbreaks. In this map of the European countries, you can see that many countries have had a significant increase in the number of cases in the last couple of years. And the big countries with current cases by incident rate are listed on this graph. And this is from a recent analysis that was done by the World Health Organization. The Ukraine and Serbia, Albania and Liberia with the highest incidence, but many other countries with very high levels of disease transmission and concern for cases. So what is contributing to our current outbreaks this year, and really even in the last couple of years here in the US? One, we know that measles is increasing globally and in many countries throughout the world. Two, we know that there's significant international travel to areas of high endemic regions. There has been an increase in a push to a term that's being used called vaccine hesitancy, which is a comprehensive term talking about reasons that people choose not to be vaccinated. And as a result of these factors, especially the vaccine hesitancy, we are seeing community pockets of low vaccine coverage. So it's a bit misconceiving if we look at the overall vaccine rates, let's say across our state, they would look quite high. But what happens is there's these small pockets where individuals, communities have very low vaccine rates, whether it's due to religious, lack of understanding or other factors, where there's a vulnerable, susceptible population. And if measles gets introduced into that setting from an international traveler or another mechanism, it is very easy for that measles virus to spread. This year, the WHO updated their list of the top 10 global threats, and I think it's important to emphasize, and we're really seeing the impact of this on public health and in clinical medicine, that vaccine hesitancy has made it into the top 10 biggest threats to our global health. They are doing a lot of work to understand what is driving this concept of vaccine hesitancy, but they really kind of have a model or framework where they discuss three kind of factors that weigh into or contribute to vaccine hesitancy. One is complacency, meaning many of us haven't seen measles, don't know the effect of it, and so people don't have that urgency to get the vaccine. Two is confidence, lack of confidence that the vaccine is effective and safe. And then the concept of convenience, that for some individuals, it may be difficult to get, their vaccine is there and they can access it, but it's not convenient. Doesn't work with their schedules. They have to drive far and factors like that. Those three big concepts vary from community to community, and which one weighs in to lead to lower vaccine rates for a certain community might vary. And it's important to consider those when we try to understand which populations are unvaccinated and what's driving the low vaccine rates. To point out, I think, some of these concepts and how it's really impacted some recent measles outbreak. This is a graph that depicts the recent measles outbreak that occurred in Minnesota in 2017. During that outbreak, they had 75 cases that were predominantly among a Somalian American community. And it was interesting in this setting, initially in the early 2000s, this population, an ethnic group, had high vaccine rates, but over time there was an infiltration of individuals who were propagating a message that vaccines weren't safe and that it caused autism. And the community bought into that, and especially younger parents chose not to vaccinate their children. And as the vaccination rates dropped, they were really primed to see a measles outbreak explode in their community. By the time the measles outbreak occurred in that community, the MMR vaccine rate was well below 50%. So what are we seeing here in the US? And I won't go through each state, but just to highlight a couple to kind of emphasize some of the key points of measles cases we're seeing here in the US. First, most of the cases at this point in time in 2019 are being observed among Orthodox Jewish communities. About 80% of the cases that have occurred have met among these communities, and largely on the East Coast. Cases from these outbreaks have actually spread now to 3 other states, but are still part of that same religious community. The other thing that has generally been observed from all the cases of 2019 is that the vast majority of cases are occurring among unvaccinated individuals. That would be expected, and what we're seeing is consistent with that expectation. Rockland County, New York is one of the outbreaks where they're continuing to see cases, unfortunately continuing to see a rise in cases. And they believe this started from the initial introduction of an individual who had international traveler and who was part of the Orthodox Jewish community. And because of close proximity, a lot of community-based events, dense population, the virus was able to spread, and there was a large number of individuals who were unvaccinated. In this community, of those that have developed measles, roughly 80% of them were unvaccinated, and 11% did not know their vaccine status. There have been cases among people who have been vaccinated, but generally that has been a small proportion of the overall cases. You can also see the age distribution, which highlights that generally in this population, most of the cases have occurred among children and young adults. The hardest population that they have had to deal with is the prior to school age children, so kids 5 and under who haven't gone to school yet and haven't needed vaccine for school reasons, but are not in time or up to date with their vaccines and have been susceptible to measles. In Washington State, it's a bit different. It's not been predominantly among the Orthodox Jewish community, but within a community that had a very low vaccine coverage rate. For school-age children in the Washington State area, where the measles virus has been spreading, the MMR coverage has been only 78% the last couple of years. We know that for measles, you need to maintain a high level of vaccine coverage at about 95% for a community in order to prevent the sustained spread of the virus. In Washington State in general, the vast majority of their cases has occurred in the young individuals and largely among individuals who are unvaccinated. Each of these states has tried to address these emergencies or public health emergencies in different ways. Some states have declared public health states of emergencies. The New York area tried to ban unvaccinated individuals from public areas, to implement harder or tighter restrictions for unvaccinated children to attend school. It's been at times met with tension and different opinions, but I think it speaks to how the burden it places on the clinical as well as public health systems. think it's important to point out a recent outbreak that has just started in one of our neighboring states, Michigan. And this outbreak started from one individual who had been working in the New York City area as a fundraiser among the Orthodox Jewish communities, and as part of his work, traveled then to Michigan to continue to raise money for a specific organization. During his transit from New York to Michigan, he developed measles, although he did not realize it at the time. And when he was in Michigan, he stayed in close quarters in people's homes, attended synagogues many times a day, and was in numerous large crowded events. During the time that he was infectious, he had been in over 30 public places. And since that time of his travel, in really about a 6-week span, there have been 42 subsequent additional cases related to that one case that was introduced into a very susceptible unvaccinated population. So what are we seeing here in Illinois? To date, for 2019, we have a total of 7 cases that have been reported to the Illinois Department of Public Health. That number is above our total number of cases from 2018, which was 5 cases. And we've seen the cases in 3 areas. We had a cluster of cases in the Champaign region. And of concern in this situation was that the first case, it was never identified where the individual may have initially been exposed. But he was unvaccinated, unclear level of exposure, but as a result, it led to a few other cases of young adults in the college age range who are also unvaccinated. That outbreak has ended after significant clinical and public health activity to temper the further spread of the virus. There was a cluster of cases related to, in the DeKalb area, unvaccinated college student returning from a mission trip to a country where the virus had been or is endemic, and a subsequent case resulted from that. And then most recently, a case in Cook County. Interestingly, in this case, an individual who had been vaccinated traveled to an area where the virus was known to be spread. When they returned here, it led to numerous potential public exposures across northeastern Illinois, requiring a lot of follow-up of individuals who may have been exposed. But fortunately, to date, there have been no secondary cases related to that first case. So moving on to the kind of the clinical perspective or clinical aspects of measles. So when we talk about measles, we typically talk about from the time of exposures to when they develop symptoms, and that's called the incubation period. For measles, that's generally about 7 to 14 days. So someone's exposed to a measles case, knowingly or unknowingly. It takes 10, 14 days until they develop symptoms. It can extend up to 21 days. That's generally the longest time or incubation period. The presenting symptoms can really mimic a lot of other viruses and other diseases. Generally, and very classically, we see a high fever, temperature of 103, 104, very high fever. People feel like they have the flu. They feel very crummy. They develop what we call the 3 C's. So they develop cough, runny nose, coryza, and then significant watery conjunctivitis. Some people also have some GI symptoms, and especially if the coryza and conjunctivitis, and there's no rash yet, are not present, some of the symptoms can really mimic flu and other viruses. After symptoms start, they progress, and generally 2 to 3 days after the symptom starts is when we start to see, if we do observe it, the Koplik spots. So these spots are things that are seen within the mouth, and I'll show you some pictures of them. They're not always recognized. They tend to appear as white, bluish, almost look like grains of sand on the buccal mucosa, and they sometimes can be surrounded by some red inflammation. After the symptoms start, it's very classic to get the rash. So, the classic presentation of measles is this high fever, the cough, conjunctivitis, coryza, the 3 C's, and then this very characteristic rash. In a classic presentation, these begins as flat red spots that appear initially on the face and traditionally at the hairline, and then essentially spread downward across the body, down the neck, the trunk, and then to the arms and legs. It's not uncommon for that to almost become these spots to join together and just have widespread areas of redness on the body. In these areas of redness can sometimes, you can note these small red bumps on top of the flatter red spots. These are not the best pictures. These are some pictures from the CDC of Koplik spots. I would say in the cases that are reported to us, 50% of the time, the clinician will identify the presence of Koplik spots. I think if you're not used to looking for them or knowing what to look for, they can be difficult to identify. And then the rash. These are very characteristic examples of the rash. So a red, flat with raised spots rash that can be spread really across the whole body, but generally starts in the face area along the hairline and then spreads downward. Measles, in general, about 1 in 4 cases will require hospital admission due to some complication, whether it's dehydration, GI complications, pneumonia, or acute encephalitis. Individuals, the most common reason for hospital admission would be the dehydration. About 1 out of every 1,000 will develop the acute encephalitis, which can result in significant and permanent brain damage. And then 1 or 2 out of every 1,000 children will die from respiratory and neurological complications. Those are very rare but fatal degenerative disease that can occur in the central nervous system that occurs many years after developing measles, and I would say is much less known. And it's not something that you would see as the initial presentation, but it is a rare and serious post-measles complication. Measles is one of our most contagious diseases that we have. It's highly contagious. What we know is that if someone who is susceptible, meaning not vaccinated and not immune in any way, is exposed, they have about a 90% chance of acquiring disease. It's very likely that if they're exposed and they're susceptible, that they're going to develop disease. It's spread through airborne mechanisms. People come into direct contact with these infectious droplets or by airborne spread of these droplets when an infected person breathes, coughs, or sneezes these droplets into the air. The measles virus can remain infectious in the air or on surface for up to 2 hours after an infected person leaves an area. So when we have an individual who has measles and they're being seen at a healthcare facility, the area that they're being evaluated in is not used after they leave for a couple of hours because we know that these droplets can stay in the air for that duration of time after an individual is in that area. As far as diagnosing and managing measles, you know, one of the things that we're really trying to push from a public health side is that initial patient assessment. Many of us on the clinical realm are not versed at seeing measles. And it can be very difficult when we are not used to seeing the clinical presentation. And so if a patient has a fever, especially a high fever, and a rash that could be clinically compatible with measles, then the recommendation is that that individual, that patient should be assessed for immunity status. Have they been vaccinated? Are they on time with their vaccine? As well as for the potential exposures. For those potential exposures, it means international travel, as well as travel to areas in the US where we know measles is occurring. If a patient presents with a clinically compatible disease, and especially if they're susceptible and or have potential exposures, we really encourage prompt reporting at the time that is suspected. This has value for several reasons. One, on the public health side, we can ensure that we assist with proper testing. If there are individuals who need to be contacted because they may have been exposed, we would be doing that rapidly to ensure if they needed prophylaxis, we could provide that. So we really encourage at the time of suspecting measles to call your local health department to report it. When there's concern of clinically compatible disease, we recommend isolation pending testing. That means promptly masking the suspected case and then placing them ideally in an airborne isolation away from other patients. If that's not possible, to place them in a room with a closed door and ensure that individuals who are taking care of the suspect patient with measles is immune, which is emphasized in this next point, that we've had many instances where it takes some time to identify someone as having measles, so the individual exposes many healthcare facilities before the diagnosis is made. And we have found time and again that some of the healthcare providers that cared for the individual did not have evidence of immunity, which leads to the concern and possibility that healthcare providers could develop disease and lead to sustained transmission. So especially if there's a suspect case, there should be the providers caring for those suspect or confirmed cases, providers should have evidence of immunity. And then the last point is the how to diagnose, confirm your clinical suspicion. So there's two mechanisms that we largely use or recommend. One is serology, and the second one is a PCR. The PCR is a molecular test that can be done at our state public health lab. Ideal to collect both a serum and a throat swab for that. If you can't do a throat swab, then you can do a nasopharyngeal swab, but that should be done as soon as clinical suspicion is present. The local health department can assist with ensuring you have the right information to collect the specimen properly. But both tests have their strengths and weaknesses and limitations, which we'll go over. So on this graph, you'll see kind of a time course of some of the different markers of disease for someone who has measles. The x-axis shows the time, and we always do time 0 is when the rash onset occurs. And then the y-axis is kind of the level of how positive that last test is. So someone is considered contagious or infectious from measles 4 days before the rash starts to 4 days after the rash starts. So that's the area or time period we're concerned about that individual potentially exposing other individuals. If someone comes in with clinically compatible disease and you want to test for measles, there's a couple options. As we talked about, the serology and the PCR. You can see on this, on the top are the gray bars that shows the virus, the PCR detection, and that generally occurs shortly before the rash starts and should be positive at the time the rash is present, but it will quickly go away 7-10 days after the rash onset. The IgM should become positive pretty quickly after the rash onset starts, but not within that first day or so. It may not be positive, which has some concerns or I guess limitations of how you use that for diagnosing. So looking at the different ways in the strengths or limitations of both tests, we have an individual who we have clinical suspicion for measles. The power of that test to diagnose measles really depends on the vaccination status of that individual. So we'll start with the most classic example of someone coming in with suspected measles who's unvaccinated. When IgM is drawn from blood, that should become positive, although it doesn't become positive that first day of the rash. Usually within 3 days, that IgM will become positive. But because we know that it may not be positive right after the rash starts, we sometimes see false negatives if it's collected within or less than 72 hours after rash onset. So the recommendation is if there's a strong clinical suspicion for measles, if the IgM is negative and it was collected less than 72 hours after the rash onset, then it should be repeated if you haven't used PCR to confirm it elsewise. The IgM will generally stay positive for 30 days. So if someone presents after the rash occurs and is feeling better, you can see positivity to the IgM up to 30 days after that presentation. But after that time, it generally reverts to negative. The PCR is usually present, detectable at the time that the rash occurs, but it rapidly declines within 7 to 10 days after the rash onset, and sometimes before that. So if it's collected many days after the rash onset, there is the potential for false negatives. So there's a high clinical suspicion. Their rash presentation or description is very classic. They were exposed to someone with measles, but they don't come to medical attention until much later after the rash develops. A negative PCR really can't rule out measles. What about an individual who was recently vaccinated? So sometimes we run into scenarios where a child gets a dose of the MMR because they're 1 year old, and then they develop a rash. It becomes complicated and a bit more difficult to interpret the IgM and PCR because the receipt of the recent vaccine can also lead to an elevated IgM. Once someone gets vaccinated with the MMR, the IgM will become positive 7 to 14 days after vaccine. So if an IgM is positive, it can be very difficult to determine. It really can't determine if that's from the vaccine response or from exposure to wild-type vaccine. In those instances, we try to collect nasopharyngeal swab to do PCRs. That too can actually have false positives to the shedding of the live virus from the vaccine. Fortunately, there is a way to distinguish between the live virus, from the vaccine virus and the wild-type virus. This at this time can only be done at the CDC. And what they do is they take the swab, the specimen, and they look to see if it's the wild type versus the vaccine type. And that's the only way to really confirm whether their presentation in a PCR positive result is due to the vaccine or due to recent exposure to measles. We also know that people who had been previously vaccinated many years ago, if they're exposed to measles, they can sometimes have a modified presentation of measles. In these instances, we know that the IgM may not develop. Thus, if there's a really high suspicion for measles, especially if a known exposure and the clinical presentation is very classic, you can't use a negative IgM to rule out disease. The same can be true, can be said for the PCR, that a negative can't definitively say that they did not have measles, but we more likely would see a positive PCR in this setting compared to an IgM. So to summarize some of the key points from diagnosing measles, as far as where you can do the test, most reference labs and or hospital labs will run serologies from serum specimens. I'm not aware of reference labs that will do the PCR and the nasopharyngeal swab. We can do that at the state lab, and there's a relatively quick turnaround time. In high suspicion cases, it can be done within 24 hours. And then when we do get a positive result, or in other unique situations, that is sent to the CDC for confirmation, and also to help distinguish, if we need to, between vaccine and wild-type virus. So to summarize, if clinical suspicion for measles is present, some of the key points for early diagnosis. 1, really strongly encourage to isolate the patient. 2, to alert the local health department of public health. We can help with isolation and help ensuring that the appropriate samples are collected and sent for testing. Along with that alert is the collection of the specimens, and we would recommend both a serum as well as a nasopharyngeal PCR. There's no treatment, antiviral medicine to use, unfortunately, to treat measles. Really, it's management of the symptoms. Some patients do require hospitalization for dehydration and or pneumonia or CNS disease. A key component of the management is to appropriately isolate the patient during their time of infectivity. which is 4 days before the rash develops to 4 days after the rash develops, and to ensure that there's appropriate case management and contact management to reduce the chance that the virus infects others. So what do we do on the public health side if we have an identified measles case or in anticipation of measles? A big message we push is prevention. The vaccine is a live vaccine, but is overall a very safe vaccine. Promoting, encouraging, educating about vaccine is an important strategy from our perspective. If a case is identified, we assist with the case investigation, as well as the monitoring and control of individuals that were exposed to that case. That's most relevant in settings where we think or know that that contact, the individual that was exposed, is susceptible. I wanted to move on to some Illinois data because with the heightened awareness and increasing measles case nationwide, it's important to understand here in Illinois where and if we are vulnerable to widespread measles outbreak. And so we've been working with the Illinois School Board of Education to look at data to understand what our vaccine rates are. The good thing is overall for our state of Illinois, the overall student vaccination rate with MMR, the measles, mumps, rubella vaccine, is just over 98%, which is great. The flip side is that for measles, we know that you need a high level of herd immunity in the community to prevent sustained transmission. So if we look at the data by county and look at the percent of schools that have or school-age children that have vaccination rate, you can see that there is some variation. There are pockets across our state where we have lower vaccination rates overall compared to other regions of the state. This looks at the data in a bit different way. And we look at school data and track it by identifying schools if they have a vaccine rate less than 95%, which is the cutoff we use for herd immunity. And then we're trying to identify how many schools in each of those counties have a herd immunity or a vaccine rate less than 95%. What you can see is that overall in our state, we have about 9% of schools that have a low or not ideal MMR vaccination rate. The reasons for the lower vaccine rates are varied. They're tracked at the state level with the State School Board of Education into the reasons why a child or a student is not vaccinated. And the general reasons are religious, scheduled, meaning that they're scheduled to get it, they just haven't gotten to the appropriate age to get the next dose. And then some individuals have medical exemptions. What you can see is that by and large, religious exemptions are the most common reason for non-vaccination across our state. What are the general recommendations for measles vaccine? So the measles vaccine series starts at the age generally of 1. There's 2 doses that are recommended for children. The first at the 12 to 15 month age visit, and then the second at the 4 to 6 year age mark. For adults, for a regular adult who's not a healthcare worker, if someone has no evidence of immunity to measles, mumps, or rubella, the recommendation is 1 dose, which generally most people have. By evidence of immunity, we assume that if they were born before 1957, except for healthcare personnel, that they're immune. If they have documentation of receipt of MMR, they have lab evidence of immunity, which can be checked by an IgG, or lab evidence of a disease. So if an adult doesn't have one of those forms of immunity, so they're not born before 1957, they don't have lab evidence, and they don't have receipt of an MMR dose, then they should receive a dose. For healthcare workers, because we consider them to be more at risk because they take care of individuals who are seeking care, and also the risk of potential further spread, the recommendation from the CDC on down is that if they don't have evidence of immunity, then they should have 2 doses, at least separated by 28 days. We do know that there was a period of time where after the vaccine was introduced, that the vaccine wasn't as effective. There were different types of vaccines. So people who were vaccinated prior to 1968 with either the inactivated killed measles virus or a measles vaccine of unknown type, these generally are considered to be non-immune individuals, and the recommendation is that they be vaccinated with at least one dose of live vaccine. There are some additional recommendations in the setting of international travel. Anyone older than 12 months of age should receive 2 doses of MMR separated by at least 28 days. We know that if live vaccines aren't, if they're given shorter than 28 days, the uptake of them is not as good. For infants who are 6 to 11 months of age and before their typical on-schedule dose at 12 months, they should get a dose of MMR vaccine. However, it should be noted that those children should also then get their regularly scheduled MMR vaccine doses. So that early dose given in a setting of international travel does not take the place of a regularly scheduled MMR dose. So what do we do on the public health side from when we get a report of a case? That case reporting starts with the reporting of a suspect case. A case investigation identifies all the potential contacts or areas, places of exposure that the individual went during their infectious period. Once we develop that list, we then try to identify directly all those contacts. There's times where we can't directly identify all those contacts. For example, if someone was in a crowded restaurant and there's no way to identify everyone who was in that restaurant. When we identify contacts, we want to assess their immunity status. One, because if it's in the appropriate period of time, we can give them post-exposure prophylaxis. And two, we want to identify if they're susceptible, because if they are susceptible, we know that they're high risk of developing the disease. So there's rules and requirements about them being isolated for a certain amount of time, as well as monitoring them for potentially developing symptoms. If someone is exposed to measles and is susceptible, they can receive post-exposure prophylaxis. Vaccine should be given within 72 hours of exposure, and that can be used as young as 6 months of age. However, it shouldn't be used for individuals with who have contraindications to live vaccine. Immunoglobulin can also be used. It helps to reduce the severity of disease. And it's generally used for the high-risk individuals and can be used up to 6 days after exposure. And then finally, there's significant effort that goes into contact monitoring. Susceptible individuals are monitored for 21 days. In certain instances, when they're susceptible, they're isolated from the school setting. Healthcare workers, if they're susceptible, would be furloughed from work up to 21 days. If they are highly susceptible, it can't be given a vaccine in time. What we do know is that when we have a public health investigation, one case leads to a large number of potential contacts. It's not uncommon for an individual to go to multiple clinical settings prior to the diagnosis, as well as numerous public settings. So there's a high concern of the risk for spread and a lot of follow-up of contacts due to one case. So in summary, unfortunately, we are seeing that measles is back on the rise. Already for this year, 2019, we have more cases compared to the entire year of 2018. In Illinois, we are not in the setting of an outbreak, although we have had 7 cases for the total of the year, which is above the number from 2018. A significant contributor to the rise in measles is the concept of vaccine hesitancy. So lowering of vaccine rates, especially in these pocket areas that make settings of highly vulnerable populations. The vaccine is highly effective and safe. And when you're diagnosing it beyond a high level of suspicion and calling public health, we would recommend, as appropriate, both the serum and the nasopharyngeal swab. Thank you for your attention, and at this time, I am happy to open it up to questions.
Great. So, Dr. Lid, it does look like we have a couple questions. Our first one is, in school, if the children went to school in infectious stage, what are your recommendations?
So it's a great question. I'm going to assume the question is both related to the case as well as the potential contacts. What happens if, and it does happen quite often, where an individual who develops measles was in school. Certainly if that happens, the case would stay home until their infectious period is over. So up to 4 days after the rash ends, or I'm sorry, the rash starts. When we have a situation where there's a case of measles in a school, one of the most immediate steps is to work with that school to review their vaccine records of all kids, especially in that classroom, but it often extends to the whole school. And the immediate public health action is that any child that's unvaccinated, so some are unvaccinated but have a religious exemption or a medical exemption, but by law, state law, those individuals are isolated, are removed from school because of the risks, the high risk for one, them developing disease, and two, transmitting it to others. So in these settings, we work really closely with the school. We review the vaccine records, identify if anyone needs post-exposure prophylaxis, and in the instances where it's needed, susceptible students are excluded from school up to 21 days.
Awesome. Another question, will insurance pay for the serology and PCR testing?
Yeah, great question. So as far as the clinically diagnosing measles, I have not heard of instances where it would not pay for the serology. As far as the PCR that's done at the state lab, that's done for free.
Our other question is the CDC considering recommending previously vaccinated international travelers getting an MMR booster?
They have not made that recommendation. You know, they do recommend that anyone who's going to travel internationally have 2 doses, which is probably not carried out to a full extent. People probably don't check their vaccine records to ensure that they have 2 doses before traveling internationally. Whether or not they'll strengthen that recommendation in any way or add a booster, I have not heard of the talk of adding a booster, but the recommendation of 2 doses before traveling is still present.
Awesome. And our last question, for a child who receives 2 doses of MMR appropriately due to travel, do they still need another dose after the age of 4?
No. So if they get 2 doses for travel, they would not need that. They would not need an additional dose. It's when they get 1 dose, you know, before a year of age, then they should stick to their regular schedule then.
Great. Well, I think that's all our questions right now, Dr. Layden. Thank you so much again for presenting on the measles. I know right now, especially with everything that's going on, this is super important. For everyone that is on and wanting CE or CEUs, everybody will receive a copy of the PowerPoint slides, a link to complete the evaluation, a link to the recording of today's webinar by the end of business day tomorrow. You must complete your evaluation by May 9th. And after this date, the evaluation will be closed and you will no longer be allowed to fill out the evaluation or receive a certificate of attendance for continuing education credit. So please make sure to fill out this evaluation as soon as you get the email, and you will receive your certificate by May 16th. Thank you again, guys, so much for joining us today.